Hello, and thank you for registering for this exciting series of 7 target antibiotic webinars. You are one of a truly worldwide audience. I'm Professor Cliona McNulty, Head of the Primary Care Unit at Public Health England. Today, and in the other webinars, we're going to discuss how you can optimise your antibiotic use and at the same time improve your patient's self-care and journey, so reducing future consultations. This first webinar, we will focus on how you can easily explore your practice prescribing compared to others, and then how you can explore your own prescribing in more detail, encouraging you to find out more about what you can do to optimise your own and your colleagues' antibiotic use. While you are watching the 20-minute video, which we'll play now, think about the questions you would like to put to our panel. You can do this by typing them into the questions pane of the control panel during or after the video. So, let's start. Let's watch the video.
So we've gathered here today to discuss antibiotic prescribing, and I think there are 3 good reasons why you should be interested as a practice in antibiotic prescribing. The first one is nationally the antibiotic resistance. We know that reducing prescribing will reduce resistance. The second one is that we know that the antibiotic usage will have profound effects on your normal flora. And the science is becoming increasingly compelling, I think, that has potentially serious consequences on health, everything from allergy to obesity. And I think that's a story that will develop. I think the biggest reason for you to be interested at the moment, given that we're all drowning in workload, is that there is very strong evidence now that if you can reduce antibiotic prescribing, you can reduce your workload. And there's also some reassuring data coming out that low prescribing practices do not see higher complication rates. So I think there's many good reasons why antibiotics are a thing that as a practice you should be interested in. So just out of interest, do you know how you do as a practice relative to other practices?
Well, we did get prescribing figures through from Ian, and we can relate those to national prescribing figures and also local prescribing figures. I wouldn't know anywhere else to look apart from that, and I wouldn't know actually where to get them myself, but I know if we request them from you that they are readily available.
Are there any websites or anything we could use to get data if we needed to, or anywhere we could go that you could signpost us to?
Sure, so there's a couple of websites which use a feed from all prescriptions. So there's the Fingertips website, which is run by Public Health England, which is a relatively simple way of seeing some high-level benchmarking data.
Do we need a login for that, or can anyone access that?
Anybody can access that. Any member of the public can access that. Okay. And I can take you through how that works briefly. And the other site that I'm increasingly using is the Open Prescribing website, which is set up by Ben Goldacre.
And will that give us data that's actually appropriate to us as prescribing individuals?
It won't give it, so it's practice level, so you can't get it below practice level. So then to ask those even more focused questions, then that's when you need to approach your prescribing advisor and start thinking about what those questions would be, going down using your practice management systems to generate that data.
Yeah, so the next level down would be that practice level data where we can look at individual clinicians and we can look in a great deal of detail as to what prescribing is happening in a particular practice.
Right.
Okay.
So I think one thing that's interesting to think about is what data sources are available to us, and there's some good national level data which we can easily access. So if we just look at some of that now for you for Lichton. So this is the Fingertips website that is provided by Public Health England. So if we just go to fingertips.phe.org.uk. So then we click on the AMR local indicators here. Then if we go on to click on the antibiotic prescribing, and then here we've got GP, Northern Eastern and Western Devon, CCG and Lichton Medical Centre. So you can see that you gave out 124.2 prescriptions per 1,000 registered patients by quarter, and that colour puts you into, I think that's the second quintile, so relatively low prescribers. So I think one has to look at this completely non-judgmentally, because we know that Linton has got a very different demographic to you here in Lichton.
Right.
But it's a starting point for discussion, isn't it? If we click here on the area profiles, you can see your practice here just represented in a slightly different way relative to all England practices, and you can see that you're sitting slightly, so that's the median there for each of these three things, and you can see that you're sitting slightly below the median for all of these indicators. So the next place I quite like is the Open Prescribing website. So they've got this look at your GP practice, which I quite like. So you can just, this has got a dashboard of things that I think the team there felt sort of were markers of good quality. So here's your prescribing dashboard. Then here we can see cephalosporins per oral antibiotic. So this is, in the blue here, you can see what's happening across England. In the red, this is your practice level data. And you can see Lichton's very much in line with national trends for that.
So you could, for instance, look at the number of antibiotics we're prescribing and see how much coamoxiclav we're prescribing as opposed to...
So let's do that. So what we can do, if we look for, say, amoxil, and we do it versus coamoxiclav.
And will that pick up all the ways amoxicillin can be prescribed? So whether it's the suspension and the caps and the tabs and the genetic and the branded? Right.
Interesting.
Particularly in North Devon, where we've got coamoxiclav almost entirely off the formulary, we should be using very little of it.
Yes.
So here you can see, so you want to be at the top end of this graph. This is over time, where do you compare to all other practices in Devon, and you can see that Lichton is at the top of that. And if you want to see it on a map,
so we are following.
So you want to be these. So you want to be these dark blues. So dark blues are what you'd expect to see. So narrow spectrum prescribing. So I guess looking at this data, I get the impression that Lichton is already in a fairly good place. You are not prescribing a lot of antibiotics compared to other practices, and when you are prescribing, they're relatively narrow spectrum. So that's a good place to start with. But I guess the next level is to go to prescribing advisors who can ask much more targeted questions and start going into the minutiae of practice here and thinking about, well, despite the fact that we're a good practice, could we be even better? And I think that's where
so I think
your data comes in.
A lot of the top line data can be used to ask some really interesting questions. Where it gets even more interesting is where you come and look at the clinical system, and you can get out some really specific points to start answering some questions and generate some more specific questions to that practice. So who are we giving these antibiotics to? And you can look at the age range, you can look at which particular clinicians are giving the drugs, you can look at the gender of the people being prescribed more, and you can get some really specific data to start asking some really sort of specific questions around who are we giving these antibiotics to, when are we giving them, and then you can go and have a look at some much more specific case reviews to really get to grips with what's happening in terms of antibiotic prescribing in a particular practice at a particular time.
So Ian's put together some slides. Now these can be done pretty much in real time, can't they, in meetings, which is quite nice.
We found that really useful. Once you've got the information out of the clinical system, you can present it in lots of different ways and really answer questions as they're coming up.
Yeah. Let's say, what percentage of women aged 20 to 40, so young women, what percentage do you think would have had an antibiotic?
Difficult one. 10%?
I'd go between 10 and maybe 20.
I was going towards 10%.
So if we look here, it's 25%.
Gosh.
27%. And we see that that's low actually compared to, that's pretty standard for all practices see the same thing. And so here we can see a breakdown by age and sex, just the percentage of people having antibiotics. So let's look at that demographic. So this is young women again. What antibiotics are you giving? So we can see that the biggest, as you would probably expect, the number one antibiotic is trimethoprim, which is our first line formulary choice for UTIs. And then flucloxacillin and doxycycline, presumably for skin and soft tissue infections. And then quite a lot of amoxicillin. It's across the board, isn't it? And a lot of UTIs, but a lot of amoxicillin as well.
I'm really surprised at that because, yes, I can get trimethoprim, but I just think that age group in antibiotics, amoxicillin, usually their mothers, with a young family, have to get on with life, or is it the opposite thinking? Is that actually to get on with life, I supposedly need antibiotics?
I think that's a really interesting observation. Actually, I think it brings us into patient expectations and what they want, and I think there's lots of things tied up in there.
And that's exactly what this data should do, so generate those specific questions. Why is this particular group getting that particular antibiotic?
I think what this does is it just starts asking those questions. Certainly when this pattern is seen in all other practices. One of the questions that people have said in the past is amoxicillin, is that all for gynae stuff? Is that the reason there's a lot of amoxicillin in this age group? The only way to address that is to go and look at the cases.
But I also like when we do prescribe, I do like the sheet that you managed to put across onto our system, so that actually when you do prescribe, that you've got this little sheet that you give to the patient. I think that's really good for patient information.
That's the link for the amoxicillin
Absolutely.
prescription.
Is this the non-prescribing leaflet?
Yeah.
Yes, I think it's really good for the patient. And so if I do prescribe an antibiotic, then I'll staple it together and then give it to the patient.
I think especially with the just-in-case scripts, it's really helpful
Absolutely,
as well.
for the delayed scripts.
Scripts, yeah.
Yeah, absolutely.
So this is the Public Health
England leaflet.
non-prescribing leaflet that you've managed to put on system one.
Yeah, so they've got a template on the system now that allows them to print it off for the patient.
Great.
Yeah, and it gives every antibiotic now, which is really good. So I think that's a good way forward.
Great. So the other bit of data, we probably could move on from data now, but there's a little bit of data here on who prescribe what and when. The highest bars here are the nurse prescribers.
Well, I think you'll find that's probably because they're in the same day team,
and
they're working in the same day team every morning and afternoon every day of the week, whereas the GPs will be taking it in turns and only doing 1 or 2 sessions a week.
And all the minor illness.
I know that you as a practice took this data and then did a month-long audit of the same-day clinics and prescribing, because I think looking at this, you see that it's the same-day clinic is where most of your prescribing is happening.
We decided to look into that and did an audit, and it was a prospective audit because it seemed to us to be the easiest way. And I think when you're looking at any of these things, it's probably the simpler you can keep it, the better. And I think sometimes you just want to get on and do something, even if it's not necessarily the perfect thing. Just do something initially and then have a think about it, reflect on it, and then make some changes from there onwards. So what we did was we looked at all the antibiotic prescriptions that were generated from the same day team over a period of a month, and that was in April. And when we did that, most of our prescriptions were for trimethoprim and amoxicillin.
Which fits in with the national.
Yeah, which is what we would have expected, isn't it, really, we found. We discussed that as a team, and we thought we'll look at the indications for trimethoprim, and most of those were actually when we looked at it for UTIs. But looking at evidence-based guidelines for antibiotic prescriptions for UTIs, it really says if a patient is symptomatic of a urinary tract infection that you should treat anyway. There's a lot of discussion about whether you should dip the urine or whether you should send the urine off, but generally speaking, if they're symptomatic with a positive dip, we would prescribe. So the other area that we could look at was the 25 patients who received amoxicillin for chest infections. And we did that and went through the notes and got all of and looked back at the patient record for those patients. So I think most GPs nowadays would say it's a really helpful, and most nurse prescribers would say it's very helpful that if you've got some evidence-based guidelines that can be easily accessed, where somebody else has done all the reading and given you some recommendations that you can easily understand, they are incredibly helpful. And this is the information we use when I reflected back on the patients' consultations where they'd received the amoxicillin prescriptions. What I did notice was that generally speaking, I thought the prescription was justified and that the patient had been seen, had had a face-to-face consultation, that a history had been taken, an examination was done which was clearly documented with clinical signs, and most of the time there was actually recognition that there was consolidation on the chest and the antibiotic had been prescribed. But truthfully, there were a couple of occasions where the antibiotic had been given over the phone without the patient being seen. And quite often that was with quite high patient expectation. And it did show us that we have got room to change and we have got room to manoeuvre and we can do better, which is not what we want to know, but what we want to know. So we got together as a team again following that survey, and we decided to go forward and try and get ourselves a prescribing template, so that if we were thinking about prescribing an antibiotic, we could actually look at some criteria on a template to say, a bit like the Centaur or fever pain score, prescribing protocol algorithms for sore throats, that we could develop something that would be practical and useful to us in the same way when doing prescribing for chests. So that is our work in process at the moment.
Great.
And hopefully that will be effective in cutting down our amoxicillin prescriptions.
I think that's a great example of going from this very high level data effectively all the way down to this very focused intervention, which is, will be great to see if it works.
Interestingly, when Ian then, because we got together as a group and we presumed that most of our antibiotic prescribing would be done in the same day team, because that's where we thought we were going to be seeing the most acute infection. However, when Ian reran the figures, probably only half of our antibiotics in that month were generated within the same day team framework. So I think we've got a lot of antibiotics that are probably on repeat prescription for COPD and exacerbations of, and those sorts of things. So there was, although we'd initially run our audit on an assumption which was erroneous, I think we still got good information out of it. We still got some areas where we can change. And I think we need to have be quite easy with ourselves and say, look, you don't have to get it right to start off with, just do something, start looking. And it has promoted change, which will be effective, even though it wasn't necessarily born from the right idea in the first place.
And I think all of the evidence shows about practices that are low prescribing practices is they just have that culture of questioning what they do. So there's a champion usually who says, I'm interested and I'm going to lead on it. And then the whole surgery working as a unit really around that. And that's when it's effective. Rather than how do I comply, it's how do I improve. And I think that's what I love working here for, because I get very much that feeling. So perhaps we're thinking now about what would we advise other people to do to take this work forward. So I think the first thing is to have a nominated lead for a practice. Think about who's going to go and get the data. Consider doing it live, I think has real power.
So probably what would be nice would be to keep something really simple so that we feel like doing it, and distribute it. All our different questions we can distribute through the whole team because we can all do it. I think one of the problems is, obviously, in general practice, everyone's busy, as you are in hospital and as you are on the prescribing team. And if we make things too onerous, I think they just won't get done. So if we can keep it really, really simple and perhaps just look at one antibiotic, and even if we're just looking for one outcome and one change of practice, if we can keep it that simple, I think it's probably something we'll be more likely to do you think?
Absolutely, and I think then that will knock on with all your prescribing, won't it, and on all your antibiotics, because by starting just looking at one thing, you then start questioning what you're doing across a whole broad spectrum of things, and I think that's very relevant to what we're doing.
Also, I think what's really nice is that in actual fact it's it's enjoyable, and also as a nurse practitioner, I think actually most of our work is actually prescribing, and it's quite a responsibility to actually put your name against a prescription, and it's enjoyable work looking at things like antibiotics, and because it's kept simple, like you said, it makes it enjoyable. We've got something up, and you do feel part of the team, and you think, oh, that's really good, and we sort of look at it, and it's good data.
Didn't you find that actually when we were doing the antibiotic audit prospectively in the same day team, everybody had a sheet during the session where they had to note down which patient they were prescribing for.
Yeah.
That in itself reduced antibiotic prescribing.
Mm-hmm.
Everybody said they thought 2 or 3 times before they wanted to put a name down on the
Absolutely.
sheet that
There was a
meant
lot
they
of
were
jesting about, hang on a minute, I've got less than you. Yeah.
A little bit of healthy competition.
Absolutely, yes.
We're a very competitive lot actually, and I think everyone wants to do slightly better than the next person and slightly better than the next practice. So,
and I guess the hope is that by doing this, that we see all of those beneficial outcomes in terms of prescribing. So reduced workload being a major one. So there's a lot of good data now showing that get your antibiotic prescribing down, you will reduce your workload.
yeah.
And then obviously the longer term effects of reducing antimicrobial resistance will fall out in many years to come.
I think one of our greatest challenges is also empowering the patient and getting them more involved in their own self-management and
Yes.
self-care.
Yes.
And that's why your
Yes.
little leaflet that you've devised on our templates are really good.
Great.
Something you can give directly to the patient to
Absolutely,
explain to them and engage them. Yeah.
absolutely.
Great. So thanks everyone.
So let's go to our panel. First of all, we've got Dr. Tom Lewis, a consultant medical microbiologist, who led those discussions you saw in the video just now. Then we've got Dr. Stephen Granier, a practicing GP in Bristol, and the Royal College of General Practitioners Target Antibiotics Clinical Lead. And finally, but very important, we've got Elizabeth Beach, who is a prescribing advisor in England and knows so much about the Prescribing Data websites you've just heard about. So we've got a few questions, and most importantly, if you've got any more questions that you think of when we're on air, please do put them in. So first of all, Steve, why should GP staff be interested in their prescribing rates?
I find that looking at prescribing data is really fascinating. I think it's a useful tool to help us to reflect on our practice. I think if we're striving to be better clinicians, then it's one of those things that can reveal some of the unknowns about our practice and help to maybe direct us as to where we need to be looking to improve our practice or where we need to be looking for learning.
What do you mean by the unknown unknowns?
With those things we don't know whether we're doing right or wrong until we can think about, what do I know a lot about, what do I know not so much about, what do I need to learn. But there are those other things that are hidden from us that we don't really know whether we're doing right or wrong because they haven't been revealed to us. So it's an external tool that can just set up a mirror, I suppose, to our practice and help us to think about some of the things that we need to look at doing differently or better, perhaps.
And we certainly heard about a few of those in the webinar, didn't we, Tom? Because they talked about amoxicillin and women and things. So,
one of the examples that I liked looking at that data in literature actually was the seasonality of flucloxacillin prescribing, which nobody's really described before, and it just raises a whole load of questions about why is that? Is it insect bites? Is it behavioural changes in the summer? And it just makes medicine more interesting, I think, really.
So, Elizabeth, one of the questions we got from Dan is how reliable is the GP prescribing data that we see on these websites?
Well, all of the primary care GP prescribing data comes from the dispense prescription process of the NHS BSA process, and then they put it back out through EPACT, which CCGs and prescribing advisors have access to, but they also supply it to NHS Digital, and that's where both Fingertips and Open Prescribing will access that data from. So the data is all coming from the same source, and it is extremely reliable data. So it's good data to use, but because of the processing of that data, it will come out with a time lag, anything from 3 months to possibly as long as 6 months. So there's an issue about the up-to-dateness of that data.
Okay. So here's another question from Jake. So what is the added value? Why do practice-based audits when we can get this other data from Prescrib and Fingertips?
Prescrib have got all of the EPAC data available with free access at GP practice level. However, none of the data that comes from the BSA has any clinical condition attached to it. And so while we can see what the volume and rates of antibiotics are being prescribed as, we don't know what they're being prescribed for. And that's where you need to move back to in practice to collect in practice data to identify exactly what condition those antibiotics are being used for.
So Steve, do you want to comment on that?
Yeah, so I mean, a lot of people are put off doing in-practice audits because of the time it takes to do them. But of course, if you have a setup where 1 or 2 people in the practice are trained to do that or have those particular skills, actually doing a basic search can take 5 or 10 minutes sometimes. And then if you share out the workload, you know, and try to get as much involvement from other clinicians as well to look at the individual, because with audit you've got to then go back and look at the notes and individual prescribing reasons. So if you try and share that out, if each of you does 5 or 10 cases, you can usually do that quite quickly, collate the data and do it relatively smoothly without too much time commitment.
So actually that brings us on to the next question from Emily. She said, how can we facilitate painless audits because they just don't have time in their practice?
Well, I think it's around those things, around finding someone, maybe equipping someone with the skills to be able to do searches, practice searches, which are not very difficult to do. And in fact, on the RCGP Target Toolkit website, there are a number of antibiotic audits that you can download and follow the recipe, basically. And then it depends a little bit on how long you want to look at. If you're looking at short periods of time, you can find a small number of patients to audit, and that can give quite meaningful data around some aspects of our prescribing.
Right. Okay. So they mentioned in the video, Tom, about antibiotic guidance. Where are people going to get that from to base their audits on and things?
So you may well have a local formulary which will have been devised with your microbiology team, and that will have been almost certainly worked up from the Public Health England guidance. So certainly our local formulary in Devon is based on the PHE primary care antibiotic formulary.
Okay.
And I think that some of the audits that we use as well are based on those. So we're looking to see to what extent practice mirrors the best practice guidance as well.
Okay. That's excellent. So Tom, Eva said, can you give us some ideas of where prescribing is often suboptimal so that we can take forward some specific searches to explore and inform their prescribing?
I mean, I guess any search you do will throw out questions, and it becomes, we'll just generate questions fairly easily. The group that we've tended to focus on is young women, because they do seem to have there's a disproportionate gap between the amount of antibiotics prescribed to women aged 20 to 40 compared to men, which is hard to explain. It feels like a very medicalised group. There is possibly an increased incidence of UTI, but it's not gynecological when you look at the data. And it's almost certainly a lot of amoxicillin prescribing for upper respiratory tract symptoms. So they're an interesting group to explore. So that's where we started, but I think the data will immediately show you questions.
And what about Steve? Have you got some ideas for, you know, what particular areas you'd want to do audits in, or what you've done personally?
Well, I think some of the things, I mean, one of the things that we looked at when I looked at our practice data is that we found while being an overall low antibiotic prescribing practice, we were a relatively high broad spectrum antibiotic prescribing practice. So we had a look at that. We were prescribing more coamoxiclav and quinolones than we thought we should be. And so we've started to try to unpack some of this data to find out what's happening in our practice. And again, you know, there are differences in the type of patients we're seeing, so it's understanding that, what conditions are we prescribing for. But we looked, for example, at coamoxiclav prescribing and what were the indications for use of coamoxiclav, and realized actually there are probably only 6 indications for coamoxiclav in primary care, and 2 of those are relatively borderline indications. We don't really know what the right things are to do in those situations anyway. But if you're aware of that coamoxiclav should probably not be prescribed very often, and you put it, you know, into a sort of second or third tier of thinking in your mind, then hopefully we'll be less likely to reach for it when we're stuck.
So let's expand on that a bit. Tom, what are the 6 areas, or between the, we can get those 6 areas?
Well,
It's a bit of a quiz, isn't it?
Yes, yeah, so facial cellulitis. So we were having a discussion around facial cellulitis as one of them. Well, let's go through them. Facial cellulitis, pyelonephritis. Yeah. There's abdominal, post-surgical abdominal wounds, which hopefully we're not seeing too much of in primary care. Diverticulitis is one of them, but again, there's no very clear guidance on how we should treat diverticulitis. And there's bites, so human bites and some animal bites, depending on which part of the body they're. I think on facial bites and maybe bites across joints. And there's one more, I can't think of. Oh, I know what it is. It's diabetics with prolonged ulcers, infected ulcers. Yeah.
So we were talking a little bit about facial cellulitis. Do we want to say any more about that? Because it's
a
bit complex.
So one thing that I get out of doing these audits is that it makes you go back to the initial guidance and question, what do people mean by facial cellulitis? Because I think it means something different to me as a microbiologist. It might mean to you reading that on a piece of paper. And I think, and again, if you actually go down to the evidence base on which that guidance is based, it's pretty weak. So to me, there's a difference between cellulitis, which is apparently related to a sinusitis, and facial cellulitis somewhere else. And it makes me think that perhaps we do need to go back to that, to the guidance, the PHE guidance, and wonder, does it actually reflect what you're seeing in practice, and does it need reviewing?
So what we're saying is that, so the facial cellulitis, we're saying co-amoxiclav to cover haemophilus and anaerobes?
So yes, probably. And again, if you look at the microbiological evidence for why that is, it's pretty weak, but probably related to sinusitis. In those situations, you get a different microbiological flora causing those problems than you do somewhere else in the face, which is a standard.
That's the reason for it.
Yeah.
But what we're saying is that if you had an erysipelas, you wouldn't treat with co-amoxiclav. And so we just have to think, are there going to be anaerobes, and are there going to be other organisms that are resistant to routine amoxicillin? So that's why, when we're wanting to use
and I think that's one thing I get out of these audits, the importance of this joint working between microbiologists and general practitioners is exploring those areas of uncertainty in a bit more detail, actually, because they can get forgotten.
Yes.
Okay. Okay, so there's a question from Joy and Alan here. Where can they find the Scottish and Welsh guidance? Or not the guidance, the Scottish and Welsh prescribing data. I do apologise.
Prescribing data does exist for both Scotland and Wales, but it's not accessible by people working in England. So they will need to contact their health boards, who would have access to that data in Wales and do have prescribing advisors, and a similar model in Scotland. So both Scotland and Wales do have the equivalent of prescribing advisors, and they do both have national prescribing data sets that they can access and they can have access to and use for reporting.
Okay. So here's one for you, Steve, from Jennifer. Jennifer's saying, are there any resources the panel can direct GP registrars to better inform them about antimicrobial stewardship and antimicrobial prescribing guidelines?
Well, a lot of the resources and guidelines are available on the RCGP Target Toolkit. So, and this has got links to all the other organisations and guidelines that are out there. So that's a good place to start.
And I would add that they can also access the Antimicrobial Stewardship Hub set up on Prescribing as a collaboration with NHS England and NHS Improvement. And this is free access and has a whole wide range of links to antimicrobial stewardship resources, including national guidance, including Target as well. And that's freely accessible, and that does include prescribing data.
Okay. Now then, so... And now, here we go. There's another one here, Steve. What is the value of looking at prescribing, even if we consider we are very good prescribers?
So this is a tricky
this is obviously for somebody who thinks they're pretty good, so why should they get any better?
Yeah. So I think there's always value in reflecting on your practice and looking at what you're doing. And again, this is one of the things I was wondering, by presenting data to people, are you likely to be complacent and say, well, actually, I'm doing really well. I don't need to make any changes. Or on the other hand, if you're an outlier and prescribing a lot of broad spectrum or a lot of antibiotics, do you just think, well, I'm overwhelmed by work. Actually, you know what, I just can't even look at this because it's just too much for me. So I think my view is that this is society's problem. Antibiotic resistance is all of our problems. We're all part of the problem, but we can all be part of the solution. We can all make some contribution to doing things better. I know that I'm focused on trying to reduce my antibiotic prescribing as much as possible, but I know that I'm way off being the best that I possibly can do. And I do see this as certainly benchmarking or peer, looking at our peers and how they do relative to me, is a useful way of reflecting on my practice. And it's not about saying you're doing it really well or you not doing so well, but it's around just all of us trying to do better at what we do. I think we can always make improvements regardless of where we fall. I think we can also look at trends, so we can look at what is our particular trend, and as we've discussed before, it then gives us the basis for deciding what do we want to explore next, what specific audits do we want to do in our practice to look at what's actually happening.
I would like to add that it's also useful to do it within a practice for your CQC inspection as an example of good practice. So you may be a very good, appropriately prescribing practice in terms of your antimicrobial stewardship, but it's really useful to be able to demonstrate that, and audit is a really helpful way of doing that.
Yes, and for appraisal and revalidation, it's one of these things that's useful for all of those programs.
And I think if you're struggling with finding resources to support that sort of audit, then there are a lot of GP practices are now directly employing practice-based pharmacists, particularly with NHS England's GP practice-based pharmacist pilot scheme. And we've been working with them to really encourage them to engage with the antimicrobial stewardship agenda. So they're there as a resource that can also help support GP practices if they're lacking the time and the resource.
Can I ask a question?
Yes.
Can I interrupt? Because one of the things that we were talking about earlier was individual GP prescribing data. So of course it's useful to know where I sit in the practice, but I'm protected a little bit by, I can always blame someone else. It's quite useful to know what I am actually doing within the context of my, again, it's got to be seen within the context of our practice, and our CCG, and where that sits in the broader range of prescribing. How easy is it to get individual GP prescribing data?
It is easy. There are two ways you can go about it. Going back to the EPAC data that CCGs have access to, that is reported down to individual prescriber level. And certainly in Bath and North East Somerset CCG, where I practice, we have started now providing that to practices, and they are finding that very useful. However, you have to interpret it in the context of what your prescribing behaviours or systems are like, in terms of if you've got non-medical, if you've got nurses who are not prescribers running triage and they are generating requests for antibiotics, that's going to be put against a GP's prescribing cost centre. So you need to bear that in mind. But you can also capture that data in practice when you do those in-practice audits, because it'll be very clear who generated and led that consultation.
That's a very good question, because somebody, I think it's Jen, has asked, is data also collected for locum prescribing data?
And I think that depends how the practice choose to allocate that locum prescriber with their code that they're working with in the practice, and that will vary practice by practice.
Okay. Here's a bit of a challenging question, and I could answer it. Somebody's asked, if guidance is based on weak evidence, should GPs follow it? So having developed the guidance for the last 20 years, maybe I'm the one who should be answering that one. I think what we do is we look at all the evidence and we look at RCTs, and then we look at prospective trials, and then if we're talking about the facial cellulitis, that what we're saying is sometimes there's very small trials, and so therefore it's done on expertise. So when it says there's weak evidence, it means that there's quite a small number of trials. And often there are very few. Microbiology isn't a particular considered exciting topic for many people, I'm afraid to say, even though we think it's exciting. And so there aren't often many studies, or they're difficult to do because there aren't many patients presenting
And
with it.
to me, what the guidance does is it sort of emancipates us from worrying about some of this detail and allows us to think about more general issues about patient management, which are possibly more important. So that's how I use guidance. It's just something else I don't have to worry about in life.
Okay.
And I think the other way that you might look at this is that if we don't follow guidance, do we open ourselves to some sort of clinical risk? And I think, and that's always one of the challenges as clinicians, because we've also spoken about balancing this tightrope of sepsis versus, in fact, that's another question we can come back to if we've got time. But I mean, sometimes what I do in this situation is to say, well, you know, the guidelines, I write in the notes, you know, why I've not followed the guidelines, why I've chosen coamoxiclav in this situation. You know, just a little brief description about why I've deviated from what, you know, might be considered best practice.
That's a really good point, because it brings up a question from Alison. So she's saying it's all very well looking at this prescribing data and doing these audits, but what about looking at outcomes, and what are we doing about that? Is there anything we can do to look at outcomes related to this prescribing data? So maybe Steve, you answer that, and then Elizabeth ponder about that, about what we're doing generally.
Do you mean
in this data?
Linking prescribing data, prescribing to antimicrobial resistance itself? Or,
well, no, I was thinking of outcomes as far as clinical outcomes. Okay. So that really comes back to the balance between sepsis and resistance. So that's...
And I think we see this as part of the same, it's answering the same problem. It's trying to target, it's using antibiotics wisely. You know, so we use, or any treatment, you're targeting treatment to the right person at the right time. And I think all the guidance, the sepsis guidance, is just it's the flip side of the same coin. You know, we try to treat everyone in the right way, and looking for signs of sepsis, or looking for indications for prescribing antibiotics for hospitalization. That's part of the clinical process that we go through. In the vast majority of patients, you know, they just need reassurance and symptomatic advice. But those guidelines, I think, are specifically around identifying the few patients and making it easier for us to identify those patients who need more intensive, more specific care.
There are some areas where you could look at some proxy measures, I guess. If you were managing UTIs and you'd taken a urine sample for culture, you could look at whether, when that report came back from the lab, your choice of empirical antibiotic had actually been appropriate. Yes. So that would be one way at looking at a clinical outcome. That doesn't necessarily relate to the patient outcome, because the patient may have got better anyway, irrespective. And you could look at patient reconsultation for treatment failure as another measure of successful outcome, and do an audit looking at reconsultation rates within that context. And then you could also look at progression to either out-of-hours presentation or walk-in centre presentation, again as another measure of unsuccessful, possibly, outcome.
Yes.
And one of the things somebody else has asked about, which I think is very important, we haven't stressed really, is about data around antibiotic resistance. Can you tell us what's available currently?
At the moment, this is where Fingertips is an absolutely fantastic resource, because they will be starting to publish the resistance data that currently Public Health England have available. Yes, and they do share that data certainly at the moment in workbooks across each of the PHE centres around England. So we know that in the southwest our E. coli and trimethoprim resistance is about 30% on average, but that actually raises as your age increases. Bearing in mind those are treatment failures that have been sent for culture. But in terms of what impact reducing inappropriate antibiotic prescribing will have on resistance is going to take quite a long time for that, I think, to filter through.
Okay, so finally, one of the questions, really, I think this is quite a good, maybe a closing question, because what approaches are being taken to help the public understanding? Because there was something mentioned in the video, wasn't there, about what we're doing? So who would like to answer that one? Steve or Tom?
What about you?
Back to me. Well, the only thing, I mean, obviously in the video, they mentioned the target antibiotic leaflet, and they were saying how useful it was. Does anybody else have any feedback about how useful it is?
Yes, we have been promoting it strongly, both the community pharmacy version, the GP version and the out-of-hours version, and patients do find it very useful because it provides them with some written information about what to expect from their illness and how to self-care and self-manage. There are also other resources. When Should I Worry? It's a really useful booklet to give to mothers of children, as is the Bristol University Target Managing Cough leaflet, which is a much simpler piece of patient information.
And obviously we'll be doing, there'll be more public awareness, and there's posters and videos available on the website as well. So that might be quite a good place to finish. So thanks guys for being grilled by our GP staff and pharmacists who all joined. So that's it for our first webinar. I do hope this has been helpful and inspired you to do more. So don't forget to explore all the materials associated with this webinar, which include links to the Prescript, the Fingertips and the Open Prescribing websites. And we can get some links to the Scottish and Welsh ones as well. And also to remember that you can re-watch the video if you want to. So also you'll soon be receiving an email asking you to reflect on how you may take forward some actions suggested in the webinar and giving us some feedback. So please do complete this if possible, as it will help us all to improve. So finally, Steve and I will be back next week. We hope to see you next Wednesday, the 9th of November, when we'll be assessing the need for antibiotics with Professor Michael Moore. So thank you, Steve. Thank you, Tom. Thank you, Elizabeth. And thank you, all of you, for joining us. And I do understand there's over 700 people who've registered worldwide. So join us again. Thanks very much. Bye.